and last but not least, I would like to introduce our final speaker for this evening, Dr. Freya Schnabel, who is a professor in the Department of Surgery, and she is also the Director of Breast Surgery here at Perlmutter Cancer Center.
Thanks, Rachel. Thank you, everybody. Thank you all for coming here tonight. We know that everybody's busy and has things to do, so it's really exciting that you thought to come out tonight. I want to thank Rachel for inviting me to speak, and I want to thank my fellow speakers because I always like listening to them too. So I'm going to give you some updates from San Antonio. I'm going to group them according to different topics. I'm actually going to give you a little bit of an overlap with Dr. Novik's talk as well. And we're going to talk a little bit first about a number of different studies that were presented at San Antonio regarding breast cancer genetics. So we all know that this is a really important burgeoning topic right now, and that we're understanding more and more about different genes that can make people susceptible to breast cancer and lots of other cancers as well. So there was a wonderful talk by Dr. Fergus Couch from the Mayo Clinic trying to help us better understand how likely it is for people in the general population and people with breast cancer to find out that they carry a gene that made them susceptible to the disease. And furthermore, when people have some of these genes that are less well known, how likely is it that those genes will then produce a breast cancer in those patients? So, first of all, why do we ever do this? Why do we do genetic testing to try to find genes that make people susceptible to different diseases? Well, we want to know who is at risk for particular diseases like cancer and breast cancer in order to help us determine which people, which women, which patients need different methods for surveillance and potentially even prevention. And it's also becoming more and more obvious that sometimes knowing that someone has a genetic predisposition to a particular kind of cancer can change the way that cancer is treated, with particular drugs being more effective in women who carry, let's say, for example, BRCA mutations. So genetic testing is increasingly important. What the researchers in Dr. Couch's study did is they got together and they tried to look at a lot of women, both with and without breast cancer, who underwent genetic testing that included a whole big panel of genes that you see on the lower part of the slide. Looks kind of like alphabet soup. You're going to see a lot of alphabet soup from me tonight. And then to try to understand how many women would be tested and find they have those genes, and then what would the results potentially be. And by the way, can I just say something? It's fine to take pictures. Yeah, no, listen.
I just got testing today.
It's fine to take pictures. I'm just going to tell you one other thing. You can go on the internet at sabcs.org, and you can find tons of material about what was presented at the conference. So it's basically everything is going to be available online.
Can you repeat
SABCS, that stands for San Antonio Breast Cancer Symposium.org. Okay, so everybody, anything that we talked about tonight that comes from San Antonio, you can actually access the slides and even some of the presentations online, which is terrific. Okay, so we're trying to figure out who's got these genes and what does it mean to them and what risks do they imply. So they looked at people both with and without breast cancer, and this gives you a sense of what the population was that they looked at. I want to draw your attention on this slide very carefully because this is going to come up in another subsequent presentation, that about 75% of the patients who participated in this trial were Caucasian, and only somewhere between 13 and 16%, on average 15%, were African American, with a very small proportion of Asian patients who participated in this trial. That's going to come up again in a minute. So what they found is that when women were diagnosed with breast cancer and underwent genetic testing, the older they were when they got the breast cancer, the less likely it was that their testing would reveal one of these predisposition genes, okay? And that totally makes sense, right? Because if you're born susceptible to something, you're probably going to get it when you're younger. So that makes sense, and they could show it. And they showed it for almost all the genes. I apologize for the fact that the graph here doesn't project terribly well. They showed this for really most of the genes, with the exception of a gene called PALB2, where it seemed like no matter what age you were tested, the frequency of finding the gene, although low, was pretty steady. But then they also tried to understand with some of these genes, particularly the ones that we're less familiar with, how likely was it that they would cause a breast cancer? What risk was associated with the genes? So you can see from the table that the highest risk genes, no big surprise here, are BRCA1 and BRCA2. I'm having a lot of trouble with this mouse, I'm just telling you. BRCA1 and BRCA2 were the highest risk genes. We kind of knew that. But when you look at some of the risks associated with the other genes, some of them are substantial and some of them absolutely are not. So PALB2, which is the partner and localizer of BRCA2, had a risk of breast cancer that is almost as high as BRCA2. But some of the other genes that people have been looking at and testing for, including genes like ATM, which you may have heard about, and some of the others, really had much less risk of breast cancer attached to them. So understanding, not just if you have a mutation, but what does it mean in terms of risk, very important. And the theme that's going to emerge from this study and from several others that I'm going to present to you are that not every genetic mutation is the same risk as BRCA1 and 2, and that is a critical piece of information to take home. Lifetime risks for breast cancer, you can look, BRCA1 and 2 are the highest, PALB2 is underneath, and then some other of the less common genes, the more common ones like CHEK2 and ATM, CHEK2 has about a lifetime risk for breast cancer of about 25%. And ATM about 15%. Now this has implications for our management. So the idea is that offering people interventions like MRI screening and even prophylactic surgery should really be interventions that we deploy in the right risk group. And Dr. Couch presents a graph like this literally every year at San Antonio, and some of these guys move around in terms of what category they fall under as we get more and more information. But again, the take-home message is we don't treat everybody like a BRCA carrier because the risks are not the same. Okay. Now, Dr. Alison Kurian from Stanford presented a very interesting discussion about breast cancer genetic testing and the results in diverse populations. So it's very clear that most of the big studies about genetic testing, and this is a table that lists them, had at least 70% Caucasian participants. And as a result, our knowledge base about the frequency of these genes and the risks that they present is really lacking in certain underrepresented groups. So it's important to know. We need to understand what the frequency of these mutations are in different ethnic groups. We need to understand about things like variants, something called variants of uncertain significance, VUSs, which are changes in the genetic code that can be seen in a gene. You remember from high school, the ACTG can be mixed up a little bit. Sometimes it doesn't matter because people are diverse. And sometimes if the code is a little bit wrong, it doesn't change anything, but that may look different among different populations. And we have to really understand this better in order to understand what we should be advising people about what to do about their genetic testing results. So they did a study where they tried to look at breast cancer patients who were diagnosed in both Georgia and California in the year 2013 and 2014. And of those individuals, there were a lot of them, 77,000, 18,000 or so had documented genetic testing results. For BRCA1 mutations, the rate of identifying a BRCA1 mutation in non-Hispanic Caucasians in this study was 2.5%, but interesting, in people who describe themselves as Hispanic origin, 5.8% had BRCA1 mutations. And that was very unexpected and suggests that we need to be very careful about thinking about people of Hispanic background and making sure that we're recommending genetic testing in an appropriate way. CHEK2 mutations had a slightly different makeup between non-Hispanic Caucasians and non-Hispanic African Americans, a big difference here. And these variants that we don't understand whether or not they're important were significantly more common in racial and ethnic minority individuals, partly because we have less testing information on them, so we do not understand the diversity of what these genes may look like in different populations. So Dr. Kurian's study that she presented really reinforces the idea that we have to expand genetic testing, get a lot more information on people who are in different racial and ethnic groups to understand better what the advice should be to those individuals. So Dr. Domchek from the University of Pennsylvania took on a different part of the whole genetic story, which is trying to give us a better understanding about women who find that they have mutations in genes other than BRCA1 and BRCA2, the so-called moderate penetrance genes, the ones that are not at the top of the list that we are really only becoming more and more familiar with now. We recognize the fact that we learned about cancer genetic testing from BRCA1 and BRCA2. That was the first big news about the ability to test for predisposition genes. And from doing what we did with BRCA1 and BRCA2, we understand the value of risk assessment. We understand the value of using prevention strategies in the right population. And we understand that sometimes the predisposition genes can have a big impact on the way a breast cancer can be treated if it should develop. We also understand that the majority of women who are tested and undergo genetic testing will not have a mutation because many of these genes are pretty unusual in the general population. And you can see that from the table here, the listed table. One of the reasons that we lower the threshold for genetic testing in Ashkenazi Jewish women is that we understand that the prevalence of BRCA1 and BRCA2 in the Ashkenazi Jewish population is about 4%. And even that is an awful lot higher than any of the numbers that you see here. But some of these genes we're not as familiar with, and as a result, we don't have a lot of good advice to tell people when they test positive for these genes. The NCCN is a national organization that releases guidelines and standards for how we should be advising and treating people with a variety of different kinds of cancers, have issued some guidelines about what we should be recommending to people with some of these less common mutations. So for ATM and CHEK2, they recommend to add MRI at 40. For PALB2, use screening MRI at age 30. But you can also see toward the bottom of the slide for some of these other genes, we simply don't know enough about them and what kind of risks they imply to have good guidelines for what to do. And part of the reason is that it's unclear exactly how much breast cancer risk these genes bring. And they've been studied by different people in different populations, and the numbers in terms of the risks that they imply vary among these studies to a fairly significant degree. For instance, with CHEK2, there are certain mutations called missense mutations that many people feel do not create any increased risk for breast cancer, whereas the truncating mutations in CHEK2, a different change in the gene, certainly shows a higher risk. Overall, it's important to remember that, especially for the genes that we're less familiar with, in order to advise someone about what their risk for breast cancer might be, it's still really important to look at the family history. Families look different. Some families skew earlier onset disease or later onset disease. If there are multiple cancers that are involved in a particular genetic mutation, families again may skew with one or another. And for genes that we're less familiar with, the numbers, the risk estimates that we have are not as reliable. So as clinicians, the advice to us is to really look at the family history to help us get a better sense of what that patient may be at risk for and at what age. Some of these genetic mutations, we really don't have enough information to even say that some different screening should be done. They're not actionable, if you will. And current guidelines are based on different opinions based on different experts and different studies, and they may even differ by country, partly because of different genetic makeup. For the genes where we're less familiar, we have to still look at family history, which is very important. And as Dr. Domchek also mentioned to us, the BRCA1 and 2 genetic risks are the highest that we know about. Many of these other mutations carry much less breast cancer risk, and we shouldn't manage every patient as if she's a BRCA carrier if she's not. So very important piece of information. And I like to show this slide when I talk about some of these moderate penetrance genes to remind you that there are other ways to have an increased risk for breast cancer. And some of the increase in risk looks a little bit like some of the risks I showed you with these less familiar genes. And so we understand that women, for instance, who have a first child after age 30 have an increased risk for breast cancer, and that's becoming more and more common in the population, and we certainly don't treat those individuals as very high risk. So we also have to put these risks in perspective. And this is from a paper published in the New England Journal of Medicine by Dr. Ellen Warner in 2011. It's a classic. I show this all the time. Okay, going on to management of high-risk patients. So Dr. Novick already talked about this study, so I'm going to run through it. I'm not really going to go talk about it too much, except I want to highlight a couple of quick points about this. So obviously, the trial was looking at whether or not we could give people tamoxifen at lower dose and for less time, but here's the important point. This study did not look at women with invasive cancer who were taking tamoxifen to prevent metastatic disease or recurrent disease. Really important. This study referred only to women taking tamoxifen to prevent breast cancer. Okay, so that's a big, big difference. So take that home. I don't want anybody thinking they should throw away their bottle of tamoxifen tomorrow, okay? Don't do it. So basically, as Dr. Novick told you, this is only about high-risk women, and the authors of the study had a lot of good information about the idea that maybe a lower dose or a shorter duration of treatment might work. And so they were able to design this interesting study where people with the appropriate risk of breast cancer were randomized and were treated for about 3 years, 500 participants, 14 centers in Italy. They very well matched, nicely designed study. And as she showed, as she indicated, the tamoxifen did show an excellent rate of prevention of breast cancer that really corresponded nicely to the classic trials of tamoxifen at standard dose. They also had less adverse events, the ones that we are really concerned about, blood clots and endometrial cancer were certainly less, and that was considered a very big win. Another thing I just want to draw your attention to, because this is a common feature of all studies of hormonal therapy, these treatments can be hard on patients. And only about 60% of the patients in either group maintained on whatever they were given for the duration of the study. And I think that number one, reminds us that tamoxifen not that easy a drug to take even in the low dose, but it's interesting that a lot of people dropped off the placebo arm too. So I don't know what to make of that, but this is a common feature. The authors felt that this is something that we could put into clinical practice tomorrow. I will tell you that our colleagues feel slightly differently. It was only 500 patients. We'd like to see this reproduced in a larger group. It is encouraging, however. But really the issue that I have with this entire effort is that we understand that while tamoxifen and other hormonal methods can reduce the risk of breast cancer in high-risk women, they do not change survival. And I think that that's also a big part of why most women who are offered these medications for prevention don't take them. They don't change anybody's survival. They do have some side effects attached to them. And this was from an editorial by Dr. Steve Nayrod a couple of years ago that I thought was going to be the nail in the coffin for tamoxifen right there, by just demonstrating the fact that since it doesn't change survival, we have to put that into consideration when we recommend it. So going on to surgical treatment. One of the real clear trends in the surgery for breast cancer over the last couple of decades has been reducing the amount of surgery that's done to remove axillary lymph nodes. So many years ago, the standard was to remove all of the lymph nodes in a particular area of the axilla. That's called an axillary node dissection as part of the surgical treatment for any woman with breast cancer. Today, we are able to offer most women a more selective removal of lymph nodes called a sentinel node biopsy or dissection. So the trend has really been to try to find a way to remove fewer lymph nodes, but yet get accurate information for the patient and then reduce the morbidity. There's a very special consideration, however, in this area for women who have disease that merits receiving chemotherapy before surgery. This is so-called neoadjuvant chemotherapy or neoadjuvant systemic therapy before surgery, which is an approach that we use for women with either locally advanced or higher risk disease. And it has a lot of advantages. The reason that this is something that we do is because it can help us prioritize the medical treatment for the cancer, medical treatment which is targeting the idea of preventing spread of disease through the body in a patient who is at higher risk for that to happen because they have extensive disease or higher risk disease, triple negative, HER2 positive, etc. Neoadjuvant therapy also allows us to monitor how the disease is responding to treatment, and that's not something that you can do if someone is receiving that treatment after the surgery. We know that there's been a lot of interest in trying to, again, modify or be more selective about the removal of lymph nodes when people who have this treatment come to surgery. So they have their chemotherapy first, and then they go to surgery. But the problem has been to ensure that it's still an appropriate and accurate way to treat these patients. And it seems pretty clear from a number of studies that in women who receive this neoadjuvant chemotherapy but have no evidence of disease in the lymph nodes, for them, we can do the selective removal of lymph nodes. The Sentinel node procedure seems to be accurate and appropriate. However, in women who have had chemotherapy before surgery and do have positive lymph nodes, it's a different matter. And there have been a number of different studies looking at this that have seemed to show that by trying to map out those first few sentinel nodes, it's not terribly accurate in this population. And those false negative rates are high enough to have been a warning issue that this may not be something that works. But if you look at this data a little bit more carefully, and Dr. Bowie did a very nice job of summarizing this for us, she showed that when women have had neoadjuvant therapy and then come to surgery, if we try to selectively remove the lymph nodes, if we do that procedure in a very particular way, we may be able to modify the surgery and remove fewer lymph nodes. We have to use mapping with both the radioisotope and blue dye. That's something we tend to do here at NYU routinely. We want to see at least 2 lymph nodes to make sure that we're getting an accurate amount of information. If the patient had disease in the lymph nodes before they began their treatment, you want to make sure that whatever lymph node was proven to have disease in it is removed at the time of their surgery. And and that's important. We have to identify that lymph node, put a little marker in it because it may not show up later on. It may not map later on. But if we do all of those different techniques, it may really be possible to modify surgery even for women with more extensive disease and allow us to remove fewer lymph nodes but still get good and accurate information. In women outside of all of those things I said, women who have clearly disease in the lymph nodes, doesn't necessarily respond to the chemotherapy, etc., then removing the lymph nodes under the arm in a more complete way remains the standard. But there is definitely movement here towards limiting the amount of surgery for the lymph nodes in these patients. So finally, I want to talk to you a little bit more about women who have had this upfront chemotherapy before the surgery. And I'm going to talk to you a little bit about this study that helps us understand about surgical choices afterwards. So the Dana-Farber, investigators from the Dana-Farber started something called the Young Women's Breast Cancer Study a number of years ago. And they enrolled younger women under the age of 40 between October 2006 and June of 2016 at 12 participating hospitals. And this was basically a way to enroll young women having breast cancer treatment and then follow them to look at their outcomes. This particular study, they looked at women who had chemotherapy before surgery and then tried to understand whether shrinking the tumor with this neoadjuvant therapy changed their surgical decision making. And this is the study cohort. They really ultimately, for this particular part of the study, only looked at information from just over 300 women. And they were a median age of about 36 years old. 61% had positive lymph nodes. And these were a high-risk group of patients, as you would imagine, because they were recommended to have chemotherapy before their surgery. So 34% were HER2 positive, 29% were triple negative. Now, what they found is that lots of patients responded to their treatment, although, not a majority had their tumors and their disease melt away. And that's not surprising. That's kind of the standard. But what they also found is that even women whose cancers shrunk nicely to the point where they didn't need to have mastectomies, they could qualify for breast-conserving surgery, 41% of them still chose mastectomies. And this was not influenced by their apparent response to treatment. And many of these, 35%, who chose mastectomy, actually had their cancers completely treated by the chemotherapy, and there was nothing left in the breast or the lymph nodes at the time of surgery. So the question is why? What was driving the engine here? And what they found by looking at the medical records of the patients is that the most common reason that they chose mastectomy was because it was their preference. So not because someone told them to, not because they had no choice, but because this is what they preferred. Many of them, 40%, had a strong family history of breast cancer or had a genetic mutation that made them more likely not only to get that breast cancer, but maybe to get another breast cancer in the future. Interesting, 75% of them who chose mastectomy actually did bilateral mastectomies. So a lot of women with bilateral mastectomies here. And these choices and the reasons for the choices didn't seem to be influenced by how women responded to the chemotherapy. So on one of the first slides I said, some people think the reason that we give chemotherapy before surgery is to allow more people to have lumpectomy surgery. Well, that certainly doesn't seem to be the case in this particular study. So what do we think here? So while the rates of giving neoadjuvant chemotherapy are increasing over time and the response rates are better than they have been before, most women are still choosing mastectomy, and these decisions are driven or appear to be driven by factors beyond the extent of disease and their response to neoadjuvant therapy. The presenters of this study had as their last statement that focused efforts to optimize surgical decision-making are needed. I don't know what that means. I think everybody gets to choose their journey. And I think that especially for younger women who had high-risk breast cancer, their overwhelming desire was to never, ever, ever go down that road again. And that's probably what was driving the engine, and it's something that I think all of us can really understand. But very interesting and a good study. So conclusions. Increasing age at the time of genetic testing is associated with a decreasing frequency of identifying genetic mutations responsible for the disease. We need to make sure that we're testing a population of women that reflects the diversity of women in America and women who get breast cancer, and we'll learn more about the genetics. Breast cancer risk estimates, there's a big range. They're kind of variable for the genes that we're not as familiar with. We got to get more familiar with them. We have to still look at family history. It may tell us a lot about how a particular gene may be acting in a particular family. Low-dose tamoxifen may provide the same benefit as standard dose with fewer associated adverse events, but we'd like to see testing of more women in a bigger study. And to reduce the extent of axillary surgery that we're going to do after neoadjuvant therapy, we've got to be careful about understanding what the extent of disease was before treatment and then after treatment. This was to the surgeons. Are there any surgeons in the audience? I don't think so. So that's for the surgeons. Use dual tracer, try to get more than 2 nodes, and clip the positive nodes before surgery. And lastly, surgical decision-making after neoadjuvant treatment is strongly driven, and this is not a bad thing, by patient preference. Thanks.